Good morning, good morning, good morning. We are trying out a new format using presentation mode within our teams. So we want to do a quick check-in, and if someone could give me a thumbs up. Can you hear me clearly? All righty, thank you, thank you. Well, good morning and welcome. We are going to get going. And as long as everyone is able to hear us, what we'll remind you is this is a webinar format, so you should be able to see both a chat option as well as a Q&A option where you can add your comments, your responses, if you have a specific question. And then as always, feel free to use the little emojis or the reaction, which I see everyone has already found. Raven, I will turn it over to you to get us started, and you tell me when you're ready to move to the next slide.
I am ready. Well, good morning, everyone. I am very excited to be presenting the research that we have been working on in the Institute of Family and Community Impact. My name is Raven Lipford. I'm the current research analyst and study coordinator of the Father's Feelings Project and the Maternal Vitality Study, which we will talk more in depth about today. Next slide, please.
And I am Brittany Pope, Assistant Vice President of Applied Clinical Sciences and Research. And oh, let's pause. So we're not seeing the slides. Thank you so very much, Carla, for letting us know that. Are you all able to see the slides now? Okay, perfect. I am the principal investigator or PI, the study author and interviewer.
So our objectives for today are 5 clear points that we want to hit. So the first one is to summarize the current mental health screening tools available for moms and dads during the perinatal period. That's kind of where our research began, looking at the current best practices and different screenings that they use and see how we can improve them. The objective two is to identify critical time points to screen for perinatal in the perinatal period for increased risk of suicidality and other perinatal mood disorders and symptoms. Third objective is to identify at least two social drivers contributing to disparities in healthcare and outcomes for Black mothers in the perinatal period. Fourth objective is to identify at least two opportunities to incorporate feedback from African American women into maternal perinatal mental health screenings. And then finally, identify at least two ways for you to support, fathers can support maternal and infant vitality.
And our hope for today is that you find yourself being able to identify different components of these objectives as you walk away. This is a really, really, really fast paced and bite sized training where we're compressing a lot of information. But one of our biggest objectives actually is to bring awareness to today, which our team didn't know existed. Apparently, October 10th is National Depression Screening Day. So, as you're thinking about the things that we want you to be able to summarize and identify, one of the biggest things is the need, the reasons why, the implications, and the heavy weight of screening for depression, today with a focus and target on perinatal mothers and fathers. So let's talk about what screening tools are there. As far as things are, at least in Ohio, we'll contextualize ourselves here. Screening for mental health is not something that you have to have only a specific professional license or degree. Screening is a piece and a part of overall prevention. How do we just universally better understand ways that we can get ahead of issues, get ahead of symptoms, or at least how can we better respond to certain groups of people where we know that they are more likely to experience a certain physical or mental health ailment, condition, or disorder. And for today, we're talking about perinatal mood disorder. If those words are new to you, let me just rewind. Sometimes we break out what we call perinatal, which is the time before, during, and after childbirth or delivery, or the end of a pregnancy. We are used to talking about postpartum and prenatal care. You go to the doctor while you're pregnant, and postpartum is afterward. Perinatal is the word that we want to think about. Any and everything that's around this time of birth, the time of delivery. And so for perinatal mood disorder, we are also thinking about a few different conditions or experiences that is not just only depression. Because not every mother or father in this perinatal period only experiences depression. So perinatal mood disorder includes depression, it includes anxiety, it includes OCD, obsessive compulsive disorder. It might include the onset of bipolar symptoms, and even something that we call psychosis. And so we are not going to go far in depth for these today, but when we share back out to all of you all attendants these slides, you'll notice that each one of these tools has a link. Excuse me, forgive me. Each one of these tools has a link and it goes to a site that where you can access the tool and also learn a little bit more about it. For today, what we do want to tell you about is what are the standardized or recommended tools for perinatal mood disorder. Those have to do with symptoms around depression, symptoms for anxiety, symptoms that we think are a little different to think about at the onset or the social role of becoming a mother, and then things that are related to psychosis. Psychosis is something that is very, very critical. It is life threatening, it is emergent and an emergency for both mom and baby. For whatever reason, and a lot of contributing reasons, but for whatever reason, the time after you've had a baby in a woman or a female mother, there's incidences of thoughts that are delusional, maybe hallucinations, really, really overwhelming and compulsive thoughts that end up in news stories that sometimes we see and sometimes we don't understand. Why would that mom drive her minivan into a very dangerous situation? Unfortunately, that mom was experiencing psychosis. And so, one of the big things that I will point out, although we're not going to go into it, when we're talking about screening for psychosis, that is not something where you screen, you do the questionnaire, and we'll follow up later. If you notice a mom is doing a little more delusional, talking to herself, seeing things not there, having these overwhelming feelings and experiences of paranoia, do not hesitate to pick up the phone and call a doctor. Do not hesitate to dial 911 or even 988, our mental health crisis and suicidality number, because one of the big things that is different for screening for psychosis, every tool on here that I'll briefly mention, mom or dad themselves can answer. Unfortunately, in a state of psychosis, you're not as aware and able and capable to answer for yourself. So I'll take that pause. I know that was heavy, but it's important to talk about and differentiate when we're saying what are these recommended tools to screen. So there are generalized tools that were created and can be used and are often used in perinatal settings, women's health settings, obstetric settings, and even pediatric settings, such as the patient health questionnaire. And that is the depression screening tool. Sometimes you see it as a PHQ-2, PHQ-8, PHQ-9, but pretty much it asks you two critical questions that kind of start to give whoever is doing the screening a hint at, Brittany might be experiencing some depressive symptoms. Let's ask more questions. And if it reaches a certain score, we think that we'll give her a referral so that someone can do a full evaluation. Same thing for the GAD or the General Anxiety Disorder Scale. It picks up on most common symptoms of anxiety. Now, PHQ and GAD, those are used universally, whether you are in the perinatal stage, male, female, and we even are using these for our teenagers. We have universal screening using the PHQ down for middle schoolers. Substance use is also something that is important to screen for, whether that is substance use that was present or risk that was there before pregnancy or that started during or after pregnancy. And you'll notice when you get this link, there are a list of various screening options because substance use disorder or substance use includes a variety of substances, sometimes things that we refer to as drugs, and maybe even alcohol as well. And then there are specific tools for perinatal health. The big standardized kind of gold standard go to is the Edinburgh postnatal depression screen. short EPDS. And so this screening tool says that, hey, we should give this to moms. And if they score more than a 10, we got to get moving. And after a while, people were like, well, don't forget about dads. Don't forget about dads. And of course, we're not going to forget about dads. But what's interesting is none of the questions on the Edinburgh was edited, just the screening criteria. Other screening tools for the perinatal period include the PASS or the perinatal anxiety screening scale. That one is about 30 something items. Not that that's a problem, but compared to the Edinburgh, which is 10, the GAD, which is 7, and the PHQ, which is 9, a lot of folks prefer shorter and quicker because the timing or the location of screening is usually within another appointment. And then lastly, as I mentioned, psychosis. There is not just one psychosis screening tool. It's usually a checklist. And the one that I provide here comes from a maternal research innovation and policy group, where they're making this as national recommendations for what to look for and what to do in response to psychosis in the perinatal stage. So timing. We promised today that we actually were going to talk about timing because one of the lenses or angles for us here at Ohio Guidestone's Institute of Family and Community Impact is what is missing, what is needed more of or differently. And one of the things that we work to do is not just look at our own research, but what are other researchers saying? And most importantly, what are we learning through public health or population health? So when we look at the most recent data that was recently published in 2023, we're seeing that moms or women are entering into pregnancy already having some symptoms of perinatal mood disorder. This could be because they had symptoms of depression and anxiety just in their life that picked up during pregnancy, or a subsequent pregnancy, mom still has unaddressed, untreated, or undertreated symptoms that she is bringing into another pregnancy. And this is occurring in at least 27% of moms. This should let us know, like, we probably need to pick up on our perinatal screening and not just focus on postpartum. We need to pick up on the prenatal screening during those months of pregnancy before childbirth. And then, excuse me, both before and during. During, about 30% of 33% of mothers symptoms are showing, but this is also the time of intensity and onset of symptoms in dad. Yes, fathers also get depression, anxiety, stress that really, really is related and unique to their experiences of being a father. Very similarly to why we're looking at this for maternal state. And then after, about 40% of mothers have symptoms that start and pick up after pregnancy. So let's look at this after pregnancy or this postpartum part of the perinatal phase. So there are some really, really critical time points where we need to ask ourselves, do I myself or a mother or a family member or a birthing person that I'm serving, when and why am I going to start this screening tool? And some people are like, oh, well, I already did it. I did what Brittany said. We started to do it, in the prenatal care, and then we did it in prenatal care. You might have to do it again because this is a continuation of possible experiences of symptoms. Therefore, we screen for it more than once. It's not one and done. So currently, national trends and practices are that mothers are screened or birthing persons are screened after the end of pregnancy, 4 to 6 weeks. So when they go to their postpartum appointment, and they often use the Edinburgh or the PHQ. However, 6 weeks is not the whole 0 to 12 months after childbirth. That's barely the first month. There are so many other time points that are critical, including what we have seen peaks between 3 to 6 months. And so the American Academy of Pediatrics recommends that we actually screen mothers, and they are pushing to ask to make sure we're screening fathers, not just at their own women's health or internal medicine appointments for dad. See, notice we don't even have a time point to screen dad. So this is why we have to think creatively, such as what the AAP is telling us. Hey, they're bringing this baby to the doctor. And most folks are pretty good at bringing their baby to the doctor. And they come a lot during that first year. So the American Academy of Pediatrics recommends that we also are screening mothers and fathers at babies 1, 2, 4, and 6 month appointments. Other things to keep in mind. We have seen a very, very stark increase in suicidality symptoms. So that might be suicidality ideation or thoughts, things that are coming up, considerations, ponderings, and even behaviors. So that might be actions that we might call an attempt. We are seeing a peak between 6 to 9 months. So our ask is that you recognize these key time points and say, I need to do something in these time points. If there is a mother, a birthing person, a father in front of me, I need to make sure that I am being responsive during those time points to start or initiate some form of screening and consider what other care, intervention, or resources this person needs. And there are some other key changes that sometimes we just have never thought about or we don't think about it in practice. The end of breastfeeding. We know that there are so many chemical or biological changes associated with a pregnant woman or birthing person's body. Breastfeeding causes so many of the same or similar cascades or pathways of bodily changes, which means it also is being found as a really, really important time point to think about, oh, body's going through changes. That means the brain, which is a part of the body, might be going through changes as well. So we need to be asking moms about their breastfeeding status. And I know for whatever reason, people get weirded out about periods. Periods are a fact of life. And if we are talking about perinatal health, it's a really important fact. So, understanding when a female woman or menstruating person, when their last menstrual period is, that's important, whether you are in a physical or a mental health phase, because not only is that information important for general mental health, outside of perinatal health, it is extremely important for the timing of when you might need to pick up or when you should add or repeat screening for mental health. So there are some gaps and some disparities in inequities. So we know that at least 13% of fathers experience paternal depression. Give me a hand raise or a thumbs up with the emojis if you've ever screened a father for depression. I only see one, and that's Raven. I see two. My point in saying that is not to be like wag my finger at you. It is to say, like, oh my goodness, if we know that this is a higher incidence of symptomology in men, why aren't we creating tools that were made for men? Why aren't we adding more into our trainings, into our professional development? Why aren't we telling dads themselves, hey, this is a part of your healthcare? Oh, I don't want to go into all of the reasons why, but we know that that is a gap and it causes a health disparity for fathers and it builds health inequity for men across their lifespan, having under addressed and undertreated health concerns. I don't have a more big word to say other than that sucks. But that's why we're working through research and innovation to create tools to be responsive to these gaps and not focus on just inequities, but to drive health equity. We know that we have this very, very weird figure. 29 to 44% of Black American women experience postpartum depression. And you might be saying, Brittany, that's a big time gap. Like, that's closer to a quarter or half. It's the emoji question mark because we have gaps and disparities in our screening practices for Black women. Either gaps and disparities for Black women being screened at all, which is something we found in our research, unfortunately, and whether those screening questions can actually pick up and identify the symptoms that Black women are experiencing. We kind of talked about, and you can imagine that our screening protocols have some representation gaps. So, are there fathers who are in the field who are thinking, like, I have some cultural and social knowledge that is very valuable? Also, representation for what are actually the experiences and the expression of symptoms for men? What are the expressions of symptoms for Black women? We know that things are not just linear and around just one group's experience. Screening timelines aren't standardized for symptom timelines. We alluded to that with a few slides before. And then we know that training is not adequate for folks to be able to train fathers, to train mothers, and then specifically Black women. Then what? So that is the question that we were looking to address and answer through our research and innovation. Raven?
Yes. So to address this gap that Brittany just talked about, there are two projects that the Institute of Family and Community Impact is looking at right now. The first is the Father's Feelings Project, in which we created and validated a screening tool for perinatal paternal depression, and the Maternal Vitality Study, where we show current screenings for Black women in the US, ask them what their feedback is, and try to create a screening tool that is culturally relevant to their needs. So, the Father's Feelings Project and the Father's Feelings interview tool is a brief paternal mental health screening, short intervention, and a warm handoff protocol for dads. So, the first screening, the enrollment visit, is where we actually screen dads using two tools: the Edinburgh Postnatal Depression Scale and the Yates Paternal Depression Screening Tool, which is a 28 screening item asking them how they felt in the last 2 weeks. After that, if they want to continue sessions with us, our research staff, they can, and there will be 4 extra consultations that they can do, which are father specific resources about baby and infant health, relationship with the mother of the baby, relationship with dad being a new dad and a perinatal dad. So, really just encouraging him and empowering him with the tools he needs to step into fatherhood in a new way.
So, what are some of our brief outcomes? So, as Raven mentioned, we created a tool. There wasn't a tool in existence in the entire international community for dads, by dads, with dads. So, that's what we did. And our Ohio Guidestones Yates paternal perinatal depression scale, we are going to just use Yates. It's a mouthful. But what we did was we wanted to see, does our tool stand up as good as or even better than a standardized tool at identifying symptoms of depression, anxiety, and for us, stress related to fatherhood in men. And so, what we found after screening 115 fathers over the last few years is that on average, fathers are having an average score on the Edinburgh of 6. And so, right now, some of the suggested cutoff scores for dad, some of them say we should go down to 5. Some of them say that we should stay at 10, and some of them say 8. So one of the things that is helping us better understand is looking at how the Edinburgh does and doesn't work for dads, but also highlighting that, hey, our tool is a little better at identifying symptomology for dads specifically to that perinatal phase. And one of the cool things that is coming out in the paper is we actually have a validated tool that is sensitive and accurate enough to pick up on depression, anxiety, and even particular co-parenting and fatherhood stress for fathers in the perinatal period. And we even have a cutoff range. And so what we know on average that dads are scoring about a 36 on our tool. And I know we're not giving you huge context because that would be another, a few pages of a research paper, but just keep your eye out for papers that are coming out. But just know that what we're finding is the Edinburgh is not strong enough to pick up on things for dads. And it doesn't have enough items that are specifically relevant or related to fathers' experiences. Whereas on our Yates tool, we were able to build this tool with dads. That is one of the cool things. We don't do research on, we don't just talk and teach to. We learn and we do research with. So when we created this tool, it was led by and had a team of men who experience, the world of mental health, both themselves as well as clinicians. Some of the folks on our teams were fathers themselves. And what we did was when we were trying out building this tool, we sent it out to as many dads that we could find across the state and asked them, is this good language? Is this the way dads and men experience things? And that gave us the opportunity to test over the last few years, what does this tool look and feel like with even more fathers? So 115 dads. And so, interestingly, on the Edinburgh, the items that had the highest scores were things that were pretty positive, that dads have been able to laugh and see the funny side of things, that dads look forward to things with enjoyment. Those items were included on the Edinburgh because, average speaking for white American women, those were two things that were really, really representative of some depressive or anxious symptoms. That might suggest that asking that to dads isn't really getting us anywhere at understanding depression and anxiety symptoms. Another thing that was interesting, that was very high, is that dads might more often blame themselves unnecessarily. So we think that is a good question to ask and think about with dads. When we looked at the Yates, the highest scores were, again, they were able to laugh and see the funny side of things. Uh-oh, sorry, I might have an error on that. Please forgive me. Other things that we recognized in dads is that they actually felt really, really happy about being fathers. And oftentimes, what happens when we are looking at, oh, here it is, sorry. When we're looking at experiences of depression and anxiety, we're looking at when you aren't happy, because that's, again, a common expression. That is not something that was common in the fathers that we screened across the state. Another thing that dads felt really, really positive about was that they are involved in the feeding, changing, and other care activities. And they felt really confident that they knew what to do to calm their baby when they were upset. And you might be thinking, like, oh, okay, well, don't ask those things. When we screen, we have to be culturally responsive, not just in the wording, the language, and the items that are on our screeners, but we want to not only just screen for things that are going wrong or problematic, we want to be able to identify strengths as well. These things let us know that these are strengths to leverage in men and fathers, their happiness and their joy about this baby, and that they know and that they want to be involved. Which means if we come across instances where a father is not able to be involved, expect that that dad might have higher stress, anxiety, and depressive symptoms, because that's a critical component of how they feel mentally well. Other things that we were a little surprised about that had lower scores were, suicidality was not common in fathers. Now, suicidality is very hard to screen for because it's stigmatized and it's taboo. So we will do deeper dives and do further analysis to make sure we're able to say, like, hey, is this or isn't this a problem or something to think about with dads? And let's say our numbers show us that, a lot of dads didn't say this. Regardless, we know that suicidality is a national problem. We're going to keep it on our screening tool to make sure we're being responsive to research and public health data. Things that a lot of folks put into expectations for fathers is angst and frustration and anxiety that might come out physically. And I felt like, where I thought of being physically aggressive with my baby, or I yelled or speak harshly to my baby. Again, these are taboo behaviors, but we did not see this picked up. And even in the fathers that we gave this assessment to when we first met them, and over a month later, after we've had a chance to build a relationship, these items did not peak in incidence either. A few other things to tell you about the dads who are in our program. We had about 44 dads who did all 5 sessions of our Father's Feelings Project, the brief intervention. On average, dads were 31 years old, but we had a range between 17 and 51-year olds. Um, and most of the fathers that we worked with, they were in the postpartum stage at about 5 months, but we did have a good amount of dads. We had 20 dads who were in the prenatal, so before childbirth stage. Although the study had a chance a few years to serve all dads throughout the state, a good amount of the work was centered in Northeast Ohio. So the most represented area code is from Cleveland, South Euclid, the Cleveland Heights area. So an urban setting with a stretch of urban suburbia. And then one of the main ways that Dad heard about the study was through Facebook. And I believe Joanne mentioned in the chat that sometimes we don't see dads talk to them. And this chart doesn't quite show it, but the main way that dads heard about the study through all of these outlets was through their mom or their grandmother or the mother of their baby. So, in case you're thinking, like, where are we going to find these dads? How are we going to get in touch with these dads? An inlet is through a family lens. through the mom of baby as well as through dad's own mother, possibly. And sometimes people are interested in tell me about these dads. The majority of dads, they were full-time employed, and the majority of fathers had high school diploma and above. Many children, excuse me, many fathers had one or two children. And one of the things that is really interesting when you look in fatherhood work is who do you co-parent with and where is mom? The majority of these fathers were either married or partnered with another woman and married or partnered with mom of baby. And the majority of them also lived in the same household. That is important when we think about the framing of co-parenting, as well as the fact that we know maternal and paternal perinatal mood disorders or, the anxiety, depression. If mom is depressed, dad is more likely to be depressed. So knowing that most of these dads were within the same household, it was important to understand and think about, oh, well, what is mom's health like as well? And if you are screening a mom for perinatal mood disorder, we got to be thinking, what about dad? And if you're screening a dad, we also have to be thinking about, well, what's going on for mom's health as well, because they're connected. So thinking about some things that we had a hunch of that might lead to greater or more likely symptoms for depression, anxiety, and stress for that was whether or not mom received prenatal care. Interestingly, a good amount of them were not sure. We think this has to do with whether dad knew what prenatal care all was comprised of or not. Whether baby had health conditions, so congenital health conditions or something that was going on at birth. The overwhelming majority was no, that wasn't the case, but about 25% that was. Um, Not all dads knew the birth outcome, and sometimes that's because of marginalization of fathers. They are excluded in these spaces. But it also lends the opportunity to educate dads more, but also educate healthcare professionals more because fathers want to be involved and they're critical. We know that dads being involved again in as support factors increases vitality and thriving of both mothers and babies. Other things that we found out that were interesting is a good amount of dads were not sure if the baby was born early or not. And that was interesting, especially considering preterm birth and early delivery is a common experience here in Ohio. So, again, we're thinking more education, but also we are looking at our next phase of analysis to see if there were some dots to connect for dads who might have been more stressed, anxious, and depressed, whereas was it connected to some of these demographics as well? One of the things that was interesting is having a better understanding if mom herself had depression or not. And so the majority of dads did not know. One of our hunches is that this is not an open conversation being had. And it should be, because again, the two conditions go hand in hand. And for looking at maternal health, one of the biggest components is whether or not she has a support system, particularly support system from her partner or from father of baby. To wrap up our preliminary preview peek of our fatherhood work, Raven is going to share some of the things that we learned from our dads throughout our conversations, interviews, and different surveys. Raven?
Yes. So I first want to start this off by saying this list is not exhaustive. Out of all of the 45 some interviews that we did with the dads who completed all 5 sessions, there were a lot of different themes that came up. But some of the big five that I did, and I just wanted to highlight for you guys today, was social isolation and the need for community social support. So a lot of the dads were saying, they wanted to have a space where they could connect with other fathers or learn more about fatherhood programming, but they simply just don't have the access or the opportunity to. A quote that I really like from one of the fathers in our project, he said, "There should be more programs for fathers in fatherhood because I know several single fathers and will recommend fathers to this program," which speaks to the need. Another one is self compassion, resilience, and advocacy. These dads are strong. Like, these dads are all about their healing journey. They were all about learning to be the best version of themselves. And in one of our study sessions, Hope and Repair, where we work on like self forgiveness, forgiving ourselves for some of the things that we did, one of the dads says that he forgives himself for caring more about his destination than his current reality. So we just see the focus on how to improve, how to get better, how to be grounded in the moment. And some of the things that we may like reserve for women, like some of the mindfulness and some of the holistic healing approaches, we see dads embracing them and like really taking it full on, which is very encouraging to see. The third one was relationship dynamics and conflict resolution. As you see, most of the dads in our study are married or partners, so there is definitely a need for relationship conflict management and dynamics, especially going from when it's maybe two people in a house to when it's two people and a baby or two people and two babies. Some of the different changes that men are going through, really, we really work to support them through that and give them healthy language, the apology languages, and just finding ways to mediate anger and mediate stress in the household. A big one that we talked about that I'm sure you guys know from your work is fatherhood stigma. So, a quote from one of our dads said, I believe that some of the stereotypes men face is dad is the authoritarian and provides. Like, I know you guys have probably heard this trope. Dad is a provider, but he's not really a nurturer. But dad is saying that we both feel the same about the care and nurturing of our babies. This dad says, we both enjoy playing video games with son. We enjoy watching UFC fights. We enjoy football. And so just reframing the idea of what nurturing is and what care for baby looks like is so important. Because although dads may show it differently, it doesn't mean that dad loves the baby any less. And so that's what we see. And of course, the last one, financial stress and need. I think that can be summed up to maybe some of the demographics, some of where we are geographically, but we are seeing that in Cuyahoga County, there is a lot of financial stress and need on these dads and families.
And one thing that we were able to do, and we say thank you to our funders later, but like we had this really cool funding with Ohio Children's Trust Fund and with their national parent organization, um, Prevent Child Abuse America, where they partnered with us to be able to give up to $400 of concrete support to dads in the way of baby safety items. And we're talking about cribs, pack and place, car seats, and it wasn't just that that was kind of like a carrot, like be in our study, get this. But people were flocking saying, thank you so very much. Like, no one ever thinks about this as dads, or like, yeah, my wife or mama, baby got this, but we needed two car seats. Or dad might not co parent in the same household. And how do you buy double for two households? And sometimes that causes an even greater inequity for the dad to be involved, which impacts his health. So we know that the financial stress and the concrete need is critical. And we say that because we live in a capitalism. Just like I asked us to be responsive to research, we have to be responsive to our systems. We can do so much. If everybody on here went and screamed dads and moms at the times we said, and we make them feel great, we give them the skills, we still have to navigate in a space where sometimes the math doesn't math if the concrete or the financial supports aren't there. So we have to recognize this too, because sometimes the sources of stress and anxiety or things that fan those flames, it's not just only our healthcare, it's the social determinants or drivers as well. So we want to make sure we're being mindful of this financial stress as well.
Okay, and moving on to our second study, we talk about dads all the time. Where I spend my other half of the time is with moms, which is a awesome part of my job. So one of the innovations that our institute has created is the maternal vitality study. This is a research study that we do in partnership with women. As Bernia said, we don't do research on, we do research with. So this study asked Black women to help us create a screening tool and protocol for maternal depression during and after pregnancy, so that perinatal period that we keep talking about, as well as other factors that impact Black women's health and wellness. And for the study procedures, we go through it by, of course, enrolling mom into program, seeing if she's eligible for the study, if she is Black, lives in Cuyahoga County, perinatal, um, not really have any major mental health disorders without therapy treatment. We get her enrolled, and then we screen. So we do the generalized anxiety disorder screening, Edinburgh, and then the index of race related stress. And then after, we have an interview with mom. So just a 20-minute interview asking, what we asked you today, are we asking the right questions? You may not feel sad all of the time, but are you experiencing headaches, or are there any somatic things that we're not capturing in this interview? Because we know that sometimes, well, all the time, cultural relevancy affects screening. So we want to make sure we're asking the right questions for the right populations to meet the need. Then after that, of course, we give warm handoff flyers and a $25 incentive for participating. Okay.
And in case you're wondering why just Cleveland, Greater Cleveland, Cuyahoga County, we were really, really, in my words, blessed with the opportunity a few years ago with our grants team to approach the Gun Foundation. And they felt like the work we were doing was aligned with the work they were doing and really responsive to the unfortunate crises that we're seeing in maternal health in Northeast Ohio and Cleveland, particularly among Black women.
Mhm.
And we also had looked at our program evaluation within Ohio Guidestone, looking at our Cuyahoga County maternal depression services. And at the time when we started this analysis in 2018 and 2019, there was an overwhelming representation of Black women in our services who had high severe symptoms, but yet through treatment, and at the time, we had a lot of representation and concordance of caregivers who looked like them, who had shared experiences and navigated some similar things, where the outcomes, looking at the programming for our maternal depression within Cuyahoga County, it showed that we were surpassing national and international best practices. That not only were moms getting better, they were coming from the most severe levels of anxiety, depression, and stress to subclinical levels. And so combining the work that we were doing and the work that the Gun Foundation wanted to do, we were able to receive a $100,000 grant to take a closer look using research to say, hey, how are we going to not just capture numbers and say, here's the numbers for Black women in Cleveland? No. And we don't want to just talk about surviving, yay, babies made it to 1 year old. Yay, this mom didn't die in pregnancy or childbirth. That's not good enough. We wanted vitality, hence maternal vitality. When we talk about things being transmitted generationally, generational stress, toxic stress, ACEs, we know that it's not just negative things, it's positive things as well. And to be fully culturally responsive, like I mentioned with dads, you do not only measure deficit and problems, we look at strength. We look at how are we able to not just survive, but build vitality, not only for mom, because we're happy to say mom's health impacts baby's health and it impacts family's health. And look at all these bad things. We can also go the other way. When
Yeah.
moms are healthy, babies are healthy, families are healthy, communities are healthy, society gets healthier. So we're unapologetic in focusing on that we didn't want to just measure negative things. And I frame that because as we go through this, you're going to hear some negative things. It's real and it's important to be responsive to. And it's also important to make sure we're recognizing how Black women are experiencing joy, how Black women are also navigating spaces so that we can learn to elevate and amp up the positives while we're also cutting down on the negative drivers of health. So I just wanted to frame that. So we are going to fast walk you through, excuse me, fast walk you through some of our preliminary outcomes of our maternal vitality study. As Raven mentioned, the study is an interview study for both Black female clinicians in Northeast Ohio, as well as moms or women. We interviewed three clinicians, and what we wanted to do was just get from them, hey, from your perspective as a clinician serving women in this maternal space, what is working, what is not working, what is really good on the screening protocol, what is missing, and then what do you do that's magical that maybe we aren't capturing in research journals, that it's not coming out in textbooks, that's not making it to the training of professionals. What do you do that is working so well for women to treat and respond to their whole health, specifically their mental health and perinatal health? Um, those studies, excuse me, those interviews are still being coded, but you won't see them here because one of the things we wanted to do is um, again, do research with. It was really important that we protect the confidentiality and privacy of these clinicians, but also amplify their voice as legit and as valuable and valid sources of knowledge and information. So they will actually be listed as co-researchers, unnamed, but co-researchers because they're contributing to the research data and literature, as well as our mom. So we had 25 moms who we screened and interviewed, and I got to give public kudos and shine to Raven for knocking that out the park. She did an amazing job. Recruitment for for community-based research is a hustle because we're not doing it in an academic setting. And sometimes we're doing it in a space where research is not what you expect, but it's so needed to make sure the voices and the lives who aren't always included get a chance to be included. The majority of the women we interviewed were between 18 and 25 and currently pregnant. So that's why we keep talking about this prenatal part, pickup screening and response before childbirth. Let's not just wait. Raven mentioned some of our perinatal mood disorder screening tools. And one of the things that we'll show you is a peek at the outcomes of those and a peek at some of the themes that we are learning within our interviews. So fast walk. So when we looked at on average across 25 moms, their depression score was about a 10 using the PHQ. And we know that a clinical score of about 5 is kind of where you start to say, like, let me ask you a few more questions. Let me see, like, should I should I give you a referral so that you can have a fuller assessment for diagnosis? um, Similar average score for the GAD or for anxiety. And then when we looked at the Edinburgh, remember the specific tool that was created for the perinatal maternal mental health screening phase, the average score was 11. And so the cutoff for the Edinburgh is usually suggested to be a 10. But there was a wide range of experiences where some mothers did not report anxiety and depressive symptoms at all on any of the tools. So that's where you see the men here. And then you see the max where there were some where they did have pretty high symptomology going on. So there were some gaps though that we noticed. So one of our perspectives or part of our concept is we use this Edinburgh, but we don't think the Edinburgh is capturing well enough for women and specifically Black women. And so when we look to see, what women had a low Edinburgh scale score, but still had a high GAD or a high PHQ score, meaning that the Edinburgh, the way it's asking questions or the language being used or what's included is not capturing what anxiety and depression looks like in Black women. So 20% of our moms, they had a Edinburgh score lower than the cutoff, but yet their anxiety score was well higher than what the cutoff was on the GAD, the Generalized Anxiety Disorder Scale. This lets us know that the way anxiety looks and feels for at least 20% of our moms, the Edinburgh is not able to capture it, which means those moms, if they would have only used the Edinburgh, they would have been unaddressed, they would have had unaddressed and untreated symptoms. When we compared the Edinburgh to the PHQ, Patient Health Questionnaire for Depression, about 12% of moms had the same phenomenon. So again, the way their depressive symptoms were being expressed in the language or the questions on the Edinburgh wasn't able to capture it the way it is on the PHQ, which again would leave those moms with unaddressed and untreated symptoms of serious mental health and illness. We looked at one specific mom where um, speaking for Raven quickly, Raven was like, this mom clearly needed support. Just listening in the conversation, even the point at the recruitment, the way they met, where they met, and mom was really, really in need of response for both, healthcare and some other resources. Mom even asked for a referral herself. Didn't matter what the screening was going to say or not say. But in this reference, if mom would have been screened with the PHQ or the GAD somewhere else, she would have received a referral. But if she would have used the gold standard for perinatal screening, the Edinburgh, she would not have received a referral by those criteria only. She would have had to push and compel and really lean into her embodied knowledge that I need something more rather than only relying on the standardized tool. And then when we looked at her race related stress scores, they were extremely high for individualized experiences of racism and global racism. And that leads us to another huge component of our concept. When we look at the Edinburgh, the PHQ, and the GAD, we see very few questions that talk about stress at all, let alone the presence of stress or the phenomenon of stress in Black American women being extremely related to their experiences of racism. You are going to notice that I use racism and not race because race in itself is a social construct. Biologically speaking, there are not biological substrates or components for racial differences. So, what that means, it is a social, an institutional, cultural, and individualized social phenomenon, not within someone's biology. So, when we say things like, oh, someone's race makes them more at risk for fill in the blank. No, 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 the conditions of racism. Or even when we say things like, oh, somebody's poverty status. Nope, little coins of metal, little pieces of paper, and I do Apple Pay, electronic form. Those things don't have the propensity to change biology directly, but it does change society. It changes institutions and it changes people's behaviors. So I really want to make sure we're framing that because as we leave here, our hope is that you have added language and we don't want you to go out and, for example, I'll put myself in the center, look at someone like Brittany Pope who had a baby 4 months early, and my medical provider told me the only risk factor you had was being black. Race is not a risk factor, but racism is. So I want to be really clear with the way we use language, and again, being accurate and strength based. So when we look at the index of race related stress, the brief form, so 20 items, easy to answer and go through, we noticed that there was a disparity in experiences and the statistics related to Black women connected to racism that we report and study and observe across the nation. We noticed that here as well for our participants. And so there are three, important domains that this tool looks at. But what we see overwhelmingly across every single participant and across several domains of this screening tool is that race-related stress was high for our Black moms. And it did not matter their socioeconomic background, their age, their mothering age, their relationship. These were experiences that were common across the board. And so there were things that were related to cultural, institutional, and just overall global racism, where at least four of the 21 questions, 89% of the moms said, yes, I experienced this. And not only did I experience this, but I experienced this at a rate that is extremely distressing, impacting my physical and mental health. So Raven will tell us quickly a few of the other codes or things that we're learning from what Mother said that we need to think about, like how can we innovate on a personal level all the way up to policy, innovation, and practice, and what more research needs to be done to keep coming up with a new strategy to improve our screening for Black women so that we don't have gaps and disparities. Raven?
Yes. So a really fun part of my job was looking at the qualitative analysis of the data. So Brittany and another one of our research team members worked on a lot of the numbers and data. I actually got to look, well, all of us, but look at the what moms are saying about some of the different things that they're experiencing and what is really going on. So four of the major things that we saw were interpersonal relationships. So mom attesting that there's something going on in the home, whether good or bad, social isolation, different relationship dynamics, and accessibility to different community resources. We also saw testimonies relating to mental health and therapy, both positive and negative experiences, parenting, and then, of course, stress. Next slide. Yep. And then some of the excerpts from our moms is there anything that you would add that I didn't ask you, but you believe should be included? That is what the research assessor asked. And they said coping with family members, speaking to social support, and also partners. How are we coping with partners? How are our partners coping with us? So really asking and inviting questions on all of these screenings that ask about the relationship dynamics between mom and the co-parent, or mom and whoever is in the household, mom and the children. That is something that was continually repeated. And then also, do you feel like any parts of the program are helpful? Yes, the questions help me better understand like postpartum and symptoms that I'm going through and everything. Just being able to talk and be able to give you my insights makes me feel better, because a lot of people don't ask for our insights on some stuff. So being able to share my insight was a good thing for me. And I think that should be really encouraging to people who screen, because they may think, oh, I'm just screening, I'm just providing, a solution, so I'm not really doing anything. I cannot tell you how many of the moms just said, like, thank you for asking me these questions. Thank you for just taking 20 minutes to ask me how I feel, because nobody has ever done it before. And so that was a personal breakthrough for me, and should be for all community behavioral health workers.
And so, what was surprising as we're going through this data, there were some things I tried to remain blind to minimize my biases. And the big takeaway for me is, Raven, what do you mean no one had asked these moms these questions? So, again, when you keep hearing me say that prenatal stage, it's imperative. And Black women are telling us, please start screening me during the prenatal phase. A policy position just dropped earlier this week from a national maternal policy center that said, hey, we got to start screening moms prenatally. So walking away from here, whatever you need to do in your context, we need to start screening moms in the prenatal period, not waiting until childbirth. So a few big takeaways from our clinicians is that we need better representation of providers, more training for both our physical and mental health providers. Physical health providers need more training on the physical symptoms they see that are representative of mental health. And mental health providers need to think about the physical symptoms as well, such as, hey, babe, what's your blood pressure like? Did you go to the doctor? Some of the things you're telling me about, you need to talk about with your regular doctor as well. We're going to do this together. Or what we are really pushing and really advocating for at the agency, integrated whole person care. The need to focus more on physical symptoms and the need to discuss the differences in fatigue for racial stressors. One of the clinicians said, I need to really break this down for you. I'm not talking about the fatigue that comes with being pregnant, the fatigue that comes with taking care of babies. She said it's the fatigue of the mental gymnastics of being a Black American woman that adds to the fatigue of pregnancy and the fatigue of caregiving. So being responsive to the way that symptoms also look across cultural experiences and cultural phenomenon. We are going to just briefly just mention that one of the biggest things that is needed is you screen and then what? We got to expedite getting mothers into services, getting through intake programs, and doing warm handoffs, not just saying, here's this information. Mom is kind of busy, either making a baby, just had a baby, or raising a baby, and maybe more than one. So thinking about also not just only referring if the number says it. That number's just a number. What are other ways that you can be responsive to making sure you're referring moms? We mentioned concrete supports. Concrete supports continue to be what we say we need more of. Suicidality screening. We need to have the questions written differently. Raven noticed that moms would answer a question, but a no for suicidality, but the conversation in the interview might say, huh. Or moms or dads would come back later and be like, yeah, yeah, I'm glad you mentioned that because I didn't want to say anything. Also, suicidality screening is not common everywhere, and it needs to be. Universal suicide screening is a must. Important. Marginalization. We need to intentionally include fathers within parent spaces. If you say parent and you don't mean mommy and daddy, then you need to revise it. Either revise the word or revise yourself in your programming. Isolation. Mothers are heavily isolated. This was a finding, even though they knew about programs, but they were not sure if they were going to be intentionally engaged. They were not sure if it was going to be welcome. They weren't sure if it was going to be safe. That reflects a lot of experiences for Black women in our country. Again, thinking about race related stress and racism, our tools need to appropriately identify sources of stress, anxiety, and depression, including for Black or racialized persons, racial sources of stress, anxiety, and depression. And we need access to culturally responsive care, folks who are culturally competent, culturally humble, culturally responsive, and also respectful. What's next for us as we wrap up with the last slide? This is one way that we say thank you to Ohio Children's Trust Fund, the Gun Foundation, and Prevent Child Abuse America for funding. Huge thank yous will be coming out to so many of our stakeholders. We have 4 papers coming out soon in research journals. And then also, we're going to keep pushing for Parental Mental Health Center of Excellence and best practice promotion. And we thank you. Be on the lookout for your CEUs and the opportunity to give feedback on this evaluation. Raven and I will stay on for about 5 minutes in case there are some questions, comments. Otherwise, don't let this be the last time we talk and engage. We have so much more to share, so much more to do. And thank you each for coming. Thank you each for the work you do. And I got to give public kudos to my beautiful, beautiful team here at Ohio Guidestone, our maternal depression services, my research assistant, and Raven, I got to give you your flowers for being a wonderful coordinator and researcher. Thank y'all.
So, Brittany, there's a question in the chat. Abigail asked, any tips on how to better screen someone who is not really interested in speaking? I had a patient recently who was a first time mom and young. The nursing staff was very concerned about her. She would not hold baby, feed baby, or change baby or look at baby. When I spoke to mom, she kept telling me she was fine and that nothing was wrong.
You could leave. So let me ask. Who asked that? Are you still on? Abigail, are you still with us? All righty. Thank you, Abigail. So, one, I would definitely say this is a good conversation to have in supervision just to talk it out because I promise you, somebody else in your setting might have more input. But one thing is that you can leave the paperwork. Screenings don't always have to be done verbally or they don't have to be proctored. Sometimes people will answer things on their own, or you might, again, talk to some of your colleagues, coworkers, and find out who might have already made an end with this mom who, kind of already vibed or, connected best or a little better. And it's not a knock on you. And see if that person can help hand out the screening tool or help get the screening tool completed. And when in doubt, be respectful and responsive to what people do and don't want to do. Thank you. That's a good question. Any other questions, David?
For now.
All righty. Thank you so very much for joining us. Be on the lookout, as I said, for follow up in regards to attendance, CEUs, and evaluation. Raven, I will end our record.